welcome to the UP Community Health Town Hall program. Tonight's program is based on diabetes, a very important topic that hits close to our region. Tonight's program is hosted by the Center for Rural Health here at Northern Michigan University, and it's organized in partnership with Dr. Kelly Kam, epidemiologist and assistant professor in the Department of Kinesiology and Integrative Physiology at Michigan Technological University. I'd like to take a few minutes to welcome this evening's guest panelists tonight. We have a number of people that are going to be talking to us from throughout the region. Kristen Kambenzi, she is the program director for the UP Diabetes Outreach Network, also called UPDON. Thanks for joining us, Kristen. We also have Michael Parks. He is the Director of Nutrition and Wellness and Diabetes Education at UP Health System Marquette. Thanks, Michael. We also have Kaylee Laquia joining us tonight. She is a registered dietitian and diabetes educator for UP Health System Marquette. Welcome, Kaylee. And Gary Daugherty is the State Director of Government Affairs for the American Diabetes Association. So we look forward to hearing from Gary tonight as well. If everybody wants to go ahead and turn on their cameras, that would be great. And Kelly, why don't you start us off with a little bit of statistics for our region to kind of bring this close to home for us?
Absolutely. So just to make sure everybody's on the same page, I found a definition of diabetes at CDC's website that I thought was a really good, easy explanation, that it's a chronic condition that basically affects how your body turns food into energy. Thought that was a nice simplistic way of being able to state it. And I think some of our speakers are going to speak to a little bit more detailed of what that exactly means. There are three different types of diabetes: type 1, type 2, which many of us have heard of, and then gestational diabetes. And I don't believe we're going to be speaking about that one at all today. In the United States, about 38 million adults have diabetes. That's about 1 in 10 adults. The majority of those are type 2, about 90 to 95% are type 2, and 5 to 10% are type 1. In Michigan, we are at about 9% of self-reported adults have self-reported diabetes. That's 2021. There's been a little bit of up and down change, but really it's kind of been flat since 2012, at least as far as the data that I've seen. In the Upper Peninsula, we're looking at about 11% of adults over 18 have diabetes. And we do see the same patterns in the UP as we see elsewhere in the United States, that men have a higher prevalence. Those with less education have a higher prevalence. As you get older, there's a higher prevalence of diabetes, and people with lower income have a higher prevalence of diabetes. One of the things that's really concerning is that about 20%, or 1 in 5 of the people who have diabetes really don't know that they have it. And so that is a concerning thing that I think is one of the reasons why we're talking about this tonight. It is an expensive disease to our systems. So it's the 8th leading cause of all deaths in the United States. In the last year, I think that's probably 2021 data, 103,200 deaths due to diabetes. The economic cost at a national scale, $413 billion every year. In Michigan, we look at about $6.3 billion each year in costs. Those are direct and indirect costs when we think about that. There's the direct cost of medical care, but also the lost wages and lost productivity related to that. Other risk factors related to diabetes: family history, if you're over 45, if you have prediabetes or ever had gestational diabetes, if you're overweight, physically inactive, and there are certain racial and ethnic groups that have a higher prevalence: African Americans, Hispanic and Latino individuals, Native American and Alaskan Natives in this country do have a higher prevalence of diabetes. And there's not only is it lead to death in cases, the risk of early death for someone with diabetes is 60% greater than those without diabetes. And the list of complications that can come from it include things like blindness, heart disease, and stroke. Also losses of toes, feet, and legs. So pretty severe disease to think about, as we have it. And like you mentioned, that there are lots of people in our area that do have diabetes, and especially that number that don't know they have it is especially concerning when we don't have, we're in medically underserved areas. The other thing that just because we started this whole thing related to COVID, I did want to make a loop back to COVID really quickly. There is that infection is associated with worsening diabetic. So COVID infection has been shown to be associated with worsening diabetic symptoms. And people who have diabetes are at higher risk of severe COVID infection. And one of the really interesting things, I don't know if if anybody else has any information on this, but there's a paper that was put out that adolescents and children who have who had COVID-19 are at an increased risk of developing diabetes 30 days after the infection compared to people who had kids who had other respiratory infections or who didn't have COVID, which is certainly as a parent a concerning thing to look at. So excuse me. So that's a little bit of background really quick of what's going on in terms of the numbers, and I will turn it over to Kristen. So again, Kristen's the program director of UP Diabetes Outreach Network, and we're excited to have her on.
Thank you for having me. As you mentioned, I'm Kristen Cambenzi. I'm the program director for the UP Diabetes Outreach Network, also known as UPDON. UPDON's been around in some form or another for almost 40 years. We started back in 1985, and it was UPDON was formed to focus on lowering the high numbers of diabetes-related complications in the UP. Throughout its history, we've been recognized by the CDC nationally, and we were at one point in time state funded. And our program was duplicated in other parts across Michigan. But back in 2008, we lost our state funding, and a lot of the other diabetes outreach networks in Michigan closed because of the loss of state funding. But UPDON was able to continue to exist and keep helping people in the UP living with diabetes. We try to focus on partnering with other organizations throughout the UP to help with the management of diabetes, and we do a UP-wide advisory council that brings diabetes educators, dietitians, nurses, just people that are interested in diabetes together twice a year to kind of discuss some of the things that are going on throughout the UP and use it to brainstorm and help bring resources to everybody.
Hey, Kristen, on that note, can you talk for a minute if there's somebody out there who fits that category that hasn't engaged with UPDON, how can they get in touch or learn more about, coming to that kind of a meeting?
Yeah, I mean, we're always looking for more people to be engaged. We usually have around 20 plus people that participate in our advisory council. They can always email me at cambensyk@upcap.org, and we can put them on our list and have them be a part of our advisory council.
Great. Can you tell us a little bit about some of the events that you've done in the UP also?
Our main fundraising event is the Swim Teal Lake Benefit for Diabetes, and that is sponsored by the West End Health Foundation. And they match all swimmer donations up to a certain amount every year. And we wouldn't be able to exist without their support. So last year we had our 20th swim. And so this next July 27th, we're going to be having our 21st swim. So it's pretty impressive that we've been able to keep that going for so long, even during COVID. We also help participate with Camp Up Peninsula. And that is a type 1 or a diabetes camp for children in the UP. And it's usually held at the Clear Lake Education Center. This year, it'll be sometime in the early part of August. And that's just a really great opportunity for kids living with diabetes to go and be kids and just have a really great summer camp opportunity. And it's really good for the parents because they get to, they know that their kids are safe and well cared for. And it's just a very unique and wonderful opportunity for kids in the UP.
Yeah, I've heard nothing but positive things about the events, that you've held, and having attended your advisory council meetings, I mean, it's very beneficial. And, I can't thank you enough for the information that you share, with our other professionals who are actually in the field, working with clients and patients and really trying to improve their health. The opportunity to be able to network and to hear about the latest and greatest, supplies and equipment and what's happening, at state levels and all that. It's really great. I know another thing that you've shared in the past has been the fact that you're actually the parent of a child that was diagnosed as being having diabetes. And I was wondering if you could give us a little perspective from the parent's point of view and kind of what you went through as well, in case there's other parents out there listening that might be feeling something or can resonate, with some experience that you might have.
Yeah, my son was diagnosed at 3.5. He's just turned 19 this year, so he's been living with it for quite a while. Looking back, you always kind of second guess yourself, like, how did I not notice that sooner? I mean, I have a picture of him from 2 weeks before he was diagnosed, and I look at it now and I'm just like, how did I not notice that he was sick? Because he had lost weight. He started, he would like drink glasses of juice like they were shots. You'd give him a glass of juice, he'd toss it back and be like, more? And he'd toss another one back. And, well, no, you're not going to have 3 large glasses of juice. And he started wetting the bed, which he never did even during potty training. And we brought him in, thought it was maybe just a bladder infection or something. And they called us later after they had taken his blood and said, you need to bring him to the ER right now. And so he was in there for almost a week while we learned how to manage diabetes. And so diabetes has been our life since he was 3.5. It's a scary time when your kid's diagnosed. But the one good thing with our son is that he does not remember not having diabetes. It's just a part of his life. So in a way, it was kind of a blessing that he was diagnosed so young, because he doesn't remember what life was like before. And it's just something that he deals with. And the amount of advances in care since he's been diagnosed are just amazing. Just amazing. I mean, the quality of life that he has now compared to when he was first diagnosed, I mean, you just can't compare the two. It's just night and day how much the advancements in technology have improved.
I think education is one of the best things about this too, because the more that you learn, whether it's how to decrease your chances of getting diabetes or how to manage diabetes, I think that's where all the knowledge is, right? That's what gives you that comfort level, and understanding that. Do you have any other events that you're kind of hoping to have come down the pipeline at all? I know you've talked about the swim and you've talked about the camp. Is there anything else that you're kind of hoping to do for the region?
In the past, we have done a diabetes summit. We usually try to aim for November since it's National Diabetes Awareness Month. And we're really hoping to bring that back. We had a little bit of a break with COVID, and we just think it is a valuable resource for getting people together and sharing information and, having, some of the diabetes supply companies there to answer questions and, having speakers and just kind of sharing experiences. Because that's one thing you learn in the UP is that, we're a very rural area, and, you could be like, for children especially, you could be the only person in your entire school that has diabetes.
Mm-hmm.
And for parents and kids and adults and everyone to get together and just kind of learn information and share experiences is just invaluable. So we're really hoping to bring that back next November.
Yeah, that's great. Well, thank you for being on the show tonight, Kristen. And thanks for everything that you do with UpDone.
Thank you for having me.
For those of you who might just be joining us, this is the UP Community Health Town Hall program. And tonight's topic is diabetes. We have a number of experts from around the Upper Peninsula here. Kristen Cambenzi, Program Director for UpDone, Michael Parks, Director of Nutrition and Wellness and Diabetes Education at UP Health System Marquette, Kaylee Lakuya, Registered Dietitian and Diabetes Educator at UP Health System Marquette, and Gary Dougherty, State Director of Government Affairs from American Diabetes Association. Next, we're going to hear a little bit from Michael Parks, wealth of knowledge and information about diabetes. He's going to talk about the difference between pre-diabetes, diabetes, and just give us a whole bunch of information. So thank you for joining us tonight, Michael.
Yeah, hello everybody, and thanks to Lisa and NMU for having me on today's discussion. I'm not going to go too much into pre-diabetes. I found that I was kind of running out of time. But my name is Michael Parks. I'm a registered nurse and certified diabetes educator and education specialist working at UP Health System Marquette as the program director for nutrition, wellness, diabetes education. Before that, I worked in the emergency department, the cardiac cath lab, and ICU as a registered nurse. As a person living with type 1 diabetes, I joined the diabetes team at Marquette with the hopes of helping people achieve their lifelong goals while also achieving their goals with diabetes. Okay. I was diagnosed with type 1 diabetes at the age of 22 while I was attending nursing school. I had been experiencing about 2 months of extreme thirst, frequent urination, fatigue, and about a 20-pound weight loss. I was admitted overnight to UP Health System Marquette, where I was given IV fluids, started on insulin, and I was educated on the, I guess you'd call it the type 1 diabetes survival skills to be able to manage my diabetes before I got to my primary care office. After that, I was discharged home, started working with a primary care provider and a diabetes educator to learn more about my disease. At first, I have to admit, it was really hard. I felt like nothing I could do was going to help me to control my diabetes. Anything I ate, it was really hard. But as I learned more about my medications, my blood glucose monitoring, and the effects of insulin, food, and activity on my glucose, it became much easier. Okay. Just like people on insulin, actually, I'm going to go back here. I do think it's important to know too that diabetes management is not perfect. It's not easy, but it is improving every day, as Kristen had said, with technologies and new medications. Just like most people on insulin, I have high blood sugars, I have low blood sugars. Okay. But as I have and continue to develop my skill set and get more educated, I spend a great deal of my time in my target blood glucose range, meeting A1C targets and reducing long-term risks and complications. As a type 1, I've accomplished many things. I'm not a believer that diabetes should hold you back in any way, shape, or form. My accomplishments include, but are not limited to, completing nursing school, playing college hockey, starting and raising a family, traveling across the US and Europe, as well as countless outdoor activities that I like to do. I do admit there are challenging days. I do have to do a lot of planning to keep myself safe, but otherwise my quality of life is very, very good. So what is diabetes? This comes from the American Diabetes Association and the Center for Disease Control and Prevention. So this is going to cross over a little bit with Dr. Cam here. Diabetes is a chronic health condition that affects how your body turns food into energy. Your body breaks down most of the food that you eat into sugar or glucose and releases it into your bloodstream. When your blood glucose goes up, it signals your pancreas to release insulin. Insulin is the key to get that glucose from your bloodstream into the cells of your body, which can actually be made into energy and used. Okay. With diabetes, your body doesn't make enough insulin or can't use it as well as it should. When there isn't enough insulin or the cells stop responding to the insulin, too much glucose stays in your bloodstream. Over time, that can cause serious health problems such as heart disease, vision loss, nerve damage, and kidney disease. Since cardiovascular disease is the number one risk with diabetes, it is important that not only do we control our blood glucose, but we also control our blood pressure and our cholesterol levels as well. Okay, now we're just going to look at type 1 and type 2 diabetes. Type 1 diabetes, as discussed earlier, makes up about 5 to 10% of all diabetes cases. It typically occurs in younger children, but it can be diagnosed at any age. In the hospital, we've diagnosed patients as old as 80 with new onset type 1 diabetes. It is an autoimmune disorder resulting in partial or more commonly complete destruction of the cells on the pancreas that make insulin. This typically leads to absolute insulin deficiency, meaning that your body no longer makes insulin. And the only treatment for that is lifelong insulin therapy at this time. Symptoms with type 1 diabetes, because of the way that the autoimmune attack occurs and the progression to to insulin deficiency or absolute insulin deficiency, is pretty sudden. Okay. So the symptoms that typically go with that are frequent urination, thirst, weight loss, fatigue, and often someone's usually admitted to the hospital with diabetic ketoacidosis where they have to be stabilized. With adults, if they're diagnosed later in life or late in onset type 1 diabetes, that progression to absolute insulin deficiency is typically slower. So often those symptoms are much more vague. Okay, so a lot of times they're treated as type 2, and over time, those medications don't typically work as well, or sometimes they get admitted to the hospital as well as time goes on. Diagnosis for type 1 is typically done through a blood test showing the presence of autoantibodies against the cells of the beta cells of the pancreas. Okay, and then with type 2 diabetes, which makes up 90 to 95% of all cases, it's a more progressive disease. Okay, this is affecting the body's ability to make or use insulin appropriately due to insulin resistance. So this means that over time, you're just really kind of just slowly making less and less insulin. With type 2 diabetes, there's both modifiable and non-modifiable risk factors. Some of them were discussed earlier, so I won't go into too much detail. But with these risk factors, it does increase insulin resistance and increase the risk of developing type 2 diabetes. Okay, the ones that are non-modifiable, the ones that we can't control, is whether we're male or female, our age, being greater than 45 years old, if we have a first-degree relative that has type 2 diabetes, and then our ethnic background. The modifiable risk factors, okay, our weight, BMI greater than or equal to 25 kilograms per meter squared puts you at risk. Lack of activity, the foods that we eat, not only the amount, but also the types of foods, especially carbohydrates, having high blood pressure, high cholesterol or cardiovascular disease, and alcohol consumption. Type 2 diabetes is often known as a silent disease. Okay, as this is progressing, there's often many, many years that you're having changes inside the body. Your glucose levels are going up. In response, your insulin levels are going up as well. But this is where it's really important that you're following up with your primary care provider, especially if you have some of these risk factors. Okay. It's important that you catch these things early, because often with type 2 diabetes, if you haven't been seen by your primary care provider for some time, you often present with complications of diabetes at diagnosis.
Mike, I have a weird question for you, but listening to you talk, when you talk about some of these things happen over a period of time, do you feel different? Do you feel something happening, or is it really not something until you go to a doctor?
Well, I think often when we see people in the hospital diagnosed with new type 2 diabetes, we talk to them about how their body's not using their energy source correctly, which is glucose. And often because type 2 happens a lot of times later in life, they're slowing down. They're not tolerating activity as well, or it's an easy excuse for them to say, well, I'm just aging. I'm just not as active, not as spry as I once was. But once they get their glucose under control and their body's using that energy source appropriately, it's amazing how much better they actually feel.
Yeah. Okay. Thanks. I didn't mean to interrupt you on that.
No, I appreciate that. So screening for type 2 diabetes should begin for all adults at age 35, regardless of risk factors. If your tests are normal, repeat screening should be done at least every 3 years, if not sooner. Okay. It should be done sooner if you have changes to your risk factors or if you have symptoms of high blood glucose. Testing should be considered earlier in all adults if your BMI is greater than or equal to 25 kilograms per meter squared, with at least one other risk factor. Mothers with a history of gestational diabetes are at higher risk, so they should have lifelong testing at least every 3 years. So diagnosis typically takes 2 abnormal blood tests. It can be from the same blood sample or a different one. If using different blood samples, it is recommended that you repeat the test as soon as possible. But it can be the same test, or it can be a different test. The most common tests that we do are a fasting plasma blood glucose, and fasting is no caloric intake for at least 8 hours, and that would be an abnormal result if you're greater than or equal to 126. And just as a reference, normal blood glucose levels do run about 70 to 110, depending on the laboratory that you go to. You can also do a 2-hour plasma glucose greater than or equal to 200 during a 75-gram glucose tolerance test. That one is not very common, but it is available. And then you have to have an A1 or approved A1C test. So it has to be a certain type of A1C that laboratories do, greater than or equal to 6.5%. And just as reference, prediabetes starts at 5.7% to 6.4%, and diagnostic for type 2 is 6.5% or higher. So normal values would be less than, or 5.6 or less. Diagnosis can also be made with one random blood glucose greater than or equal to 200 milligrams per deciliter, with classic symptoms of high blood sugar, frequent thirst, urination, fatigue, that kind of stuff. After diagnosis, it is important that you follow up with your primary care provider, having regular physical exams and labs drawn at least annually. Labs should be done more often, pending your specific health risks and overall glucose control. You may also be referred to a certified diabetes educator like myself for Kaylee, where we can become part of your diabetes team and assist you with the skill sets needed to manage your diabetes. The more you learn, the easier it's going to be on you. So I really push everybody to make sure they're learning about their diabetes. But we also, not only do we educate people, we also help with the stress. There's a lot that goes into diabetes and managing it. And we help you through that process. We may help you get on the appropriate medications. And as technologies are coming out, primary care offices are struggling to keep up with them. That's where we excel, with continuous glucose monitors, insulin pumps, and some of these newer medications. So with blood glucose monitoring, the gold standard for diabetes control is still your hemoglobin A1C level, to evaluate long-term risks for complications of diabetes. And really, this should be done at least 1 to 4 times a year. If you have really poorly controlled diabetes, you should be getting your A1C done every 3 months. If it's better controlled, your provider may only do it once annually, depending on your control and the consistency of that control. Typically, the goal is to achieve a hemoglobin A1C level less than 7%, and that goes with an estimated average glucose of about 154. And the goal here is we want to achieve these values safely. We want to have minimal low blood glucose events. So depending on someone's age, the likelihood of their lifespan, their overall health, and risk for low blood sugar, we may back off those targets, because having extreme low blood sugars may be more dangerous for them. When we look at management, high blood sugars take time to cause injury. One severe hypoglycemic or low blood sugar event can cause injury up to death, it is very important to understand and know that. So on a daily basis, we use blood glucose meters and continuous glucose monitors, or CGMs, to evaluate our day-to-day glucose control, assess our risk for low blood sugar, and our glycemic response to certain foods and activity. Your testing regimen will depend on your overall control, the medications that you are on, your age, and your risk for low blood sugar. If your control is poor and your risk is high for lows, more frequent monitoring would definitely be recommended. It is important that you understand your blood glucose monitoring routine, your targets. We want to know, when you're checking, you want to know where you should be. And it's really important that you should know when to call your primary care provider for adjustments of your medications, especially on the low end.
Michael, can you tell us a little bit about long-term complications that people would have from having diabetes if it's not in control? Like,
yeah, so the number one risk factor is cardiovascular disease. When you think about, glucose being in your bloodstream, it does stick to the vascular system or the vessels inside your body. And typically, if that's going to cause any issues first, it's going to start with the smaller vessels. So it's going to be, the ones that provide blood flow to our nerves or to our feet or extremities for healing, our eyes. So those ones are kind of some of the more common ones early is, poor wound healing, neuropathies, eye damage. But as diabetes continues to be uncontrolled, it starts to affect the larger vessels or the macrovascular system in our body. So that becomes the risk of heart attack, stroke, kidney disease.
Okay. I know Kelly and I were just talking about eye exams related to diabetes when we were talking about this upcoming program and how important that is, for people to have their eyes checked on a regular basis. So
it's a really good non-invasive way for providers to look at your vascular system through a dilated eye exam. So
you talked a little bit about blood glucose monitors. And I know Kristen kind of hinted to this earlier, but technology has come a long way when it comes to management of diabetes. For as long as you've been in this, Michael, I mean, what have you seen it go from one extreme to another? And, do you think it's made it a lot easier for people to at least understand?
Yeah, absolutely. I mean, I think right now, obviously we're using technology more than we ever have. I've been in this department since 2015. Prior, but I think as you're looking at it, an insulin pump was an option back in the day. But it definitely did help to control the levels, but where we're at now using continuous glucose monitors along with insulin pumps, they're working together. They're looking at your continuous glucose monitor value, your trend arrow, and they're automating a lot of the insulin delivery to either, continue the current therapy, slow it, stop it, increase it, all with the goal of it to keep your diabetes in your target range. So we're not just seeing it for type 1 diabetics. I mean, because of the success that we're having with these technologies, we're now seeing it being used very widely in type 2 diabetes as well. Continuous glucose monitors are really kind of taking over, poking your finger and just getting a simple blood glucose value, because that value only shows you where you're at right now. It doesn't show you where you were or where you're trending. With a continuous glucose monitor, it's graphing everything out and it's giving you trend arrows and things like that to help predict your diabetes going forward.
Mm-hmm. Well, if there was one thing that you wanted people to take away from tonight, Michael, what would that be? What would you want to share with people who are able to listen and watch this program tonight?
Living with diabetes myself, it is a challenging disease. Okay. But I do feel that the more you learn about it, when my glucose levels aren't where I want them, I understand that there are risks to my body and my future. But I'm just not okay with that. I like to be a detective, and I really push patients to understand where their glucose value should be and how to get them back on track. So what I like to say is, like, be a detective, answer the why is your glucose at this value? Assess your activity, assess the foods you're eating, assess your stress level. Because if you're able to get yourself back on track, you're ultimately going to be able to meet a lot more of your life's goals.
Yeah, that's great advice. I also think that's good for, some of the people that are doing caregiving for individuals who might be diagnosed too. Not to be afraid, but to really try to understand it.
Absolutely.
Yeah. Thank you, Michael. This was great. And just when you think there isn't more to know about diabetes, we get to hear from Kaylee. Kaylee is going to talk about from her perspective as a registered dietitian and a diabetes educator, the importance of nutrition and diet and exercise. And welcome to tonight's program, Kaylee.
Thank you. And I apologize in advance for my audio. But right, so no matter what type of diabetes, nutrition is something that really can affect how you manage your blood sugars. So when I get a client coming in to discuss diabetes nutrition, we always go over consistent carb and the plate method, which the plate method is an approved tool by the American Diabetes Association to teach evidence-based guidelines for the nutrition therapy. What the plate method basically is a balance of roughly a quarter of the plate being a carb source, the other quarter being protein, and then that remaining half non-starchy vegetables. And we'll get in a bit more into that. So what I mentioned, the plate method and consistent eating, both are extremely important for blood sugar regulation. And as Mike had mentioned, that our bodies run on carbs. They love carbs. It's what they're designed to use as fuel. But when we have diabetes, there's some metabolic dysregulation going on. The body's not able to process or use those carbs like intended. So in order to benefit our metabolism, kind of get it back on track and be fueling our body consistently, we have to fuel it with those carbs. That being said, there is some strategy on how we fuel to manage our blood sugar properly. So all carbs essentially are chains of sugar. Some carbs are simple and they're smaller chains, and others are complex and they're in these long, complex structures. And these chain sizes basically dictate how quickly or slowly the sugars are going to break down and get absorbed into your body. Or into your blood, rather. So some examples of a complex carb would be things like our whole grains, oatmeal, wheat, whole grain breads, wild rice, popcorn. But it could also be things like whole fruits with the skins, beans, baked potatoes with the skins, or even milk or yogurt, I would consider a complex carb. So generally what makes a carb complex is the fiber that's in it. But in the case of milk and yogurt, it would be the fact that there's fats and proteins along in with that sugar. Simple carb, those smaller chains, or the quickly digesting absorbed sugars, those are going to be things like those refined grains, or our white breads or pastas. Cereals tend to be on the simpler side. Fruits without skins or fruit juice, or things with a lot of added sugar. So think regular old Coca-Cola or stuff like candy and desserts. So when the simple carbs break down and they get absorbed really quickly, this is going to cause a blood sugar spike. And when complex carbs get broken down, they absorb more slowly. So we get that kind of gradual peak in our blood sugar. So if the goal of diabetes is to manage our blood sugar, or meaning keeping our blood sugar more even without these large spikes, complex carbs are going to be the better choice to make that happen. So we talked about the carb part. What about the non-carb portion of our plate method? So proteins and non-starchy vegetables. Proteins are going to be things like our meats, cheese, eggs, peanuts, almonds, that kind of thing. And then non-starchy vegetables really are the majority of our vegetables, with exception to beans, corn, peas, potatoes, and big squash. So basically we want that balance. We have our plate method. We need a balance of our carb with our non-carbs. And then that consistency portion is going to be about keeping that metabolism fueled and more regulated. So what I really mean by this is that we should be eating that carb with a non-carb every 3 to 4-ish hours. And it's going to kind of depend what your schedule looks like, whether that's 3 meals and a snack, or maybe even 3 meals and a couple snacks. it's kind of dependent on the individual. And so it's definitely one of the factors that is a big factor in diabetes. But there's others. So in addition to our sleep habits and our stress levels, we also have activity that's going to make a big impact. When we're active, our body pulls that sugar from our blood to use for the fuel. So quite literally, we'll lower blood sugar pretty quickly, depending on the kind of activity. So another thing with activity is that it has to be consistent as well, because the more consistent we are with our activity, the better our body's going to be at using that insulin and getting the fuel in to use as for the fuel of the muscles. So far as the ADA guidelines, or American Diabetes Association, they suggest 150 minutes a week or more, of course. And this should include some sort of resistance training and a cardio aspect. The resistance training could be body weight or with weights or resistance bands. And then more specifically, they also recommend splitting that 150 minutes into no smaller increments than 15. Or 15 minutes. So it could be 5 days of 30 minutes a day, or more like 10, 15-minute increments spread out. Specifically, if we can do that activity after eating, kind of like I'd mentioned, it's going to take the sugar out of the blood. That would be the most beneficial. So another thing is, I keep saying consistency. So something I always make sure to talk about is that when we are making these changes to our nutrition and our activity habits, we have to make sure that they are something we can actually sustain. Not something we're gonna hop on board with for 3 months, or while the weather's nice in the summer or something in the UP, and then we're gonna abandon it for the rest of the year. Because so often I see people maybe get a new diagnosis, or even they've had this diagnosis, but they get their A1C and it's high and it normally isn't. And they think, oh my gosh, I need to make all these huge changes in my diet. I need to drastically change everything about my life. And usually what follows that is a lot of burnout, or of course, life gets in the way and we can't keep up with such strict guidelines or habits. Definitely a huge part of the counseling that I do is that we learn and we get the education on these things that can help, but also how to sustainably add them into our life.
Great, thanks, Kaylee. I have a question in terms, my kids are collecting at the schools. They're doing a lot of food drives, and certainly this time of year, there's lots of donations to food banks. And given the numbers of people with diabetes and pre-diabetes up here, are there foods that are shelf stable that would be better to donate to some of the food drives, or ones that are certainly worse? I typically end up with mac and cheese, and that doesn't sound like it's the greatest option for someone who might be one of those undiagnosed prediabetes or diabetics.
I mean, canned things definitely, and packaged things can have their space for sure. If we are going to do things like a canned fruit per se, trying to make sure that it says 100% juice rather than packaged in heavy syrup, because even though that juice, we'd mentioned that that's also a simple carb, it's not quite to the extent of that heavy syrup that it's in. But I mean, other things, any type of canned vegetable, canned fruits in that juice. They make wonderful little packets of rice that go into the microwave that come in all kinds, the wild rice, the brown rice. And proteins, chicken and tuna. I find that protein tends to be the most expensive for people. So the canned stuff, or they make the little envelopes of flavored tuna and chicken type thing. Yeah, other types of pasta. They do make different pastas, wheat pasta or like protein pasta. It's going to be a little bit different than like the mac and cheese that you mentioned. Yeah,
Thanks. I think
stacks of potatoes.
All right, thanks very much. That really helps with thinking about shopping more thoughtfully, I guess.
Yeah.
we're going to move on. We've got our last speaker tonight, Gary, if I'm going to pronounce this correctly, Darty, is that right? So Gary's going to be speaking from the American Diabetes Association, the State Director of Government Affairs. So welcome, Gary.
Thank you. Thanks for the opportunity to join the panel. I've enjoyed the discussion so far and looking forward to sharing a little bit about diabetes advocacy. First of all, for context, the American Diabetes Association is the nation's leading voluntary health organization fighting the diabetes epidemic. We were founded in 1940, and we are comprised of people with diabetes, healthcare professionals, research scientists, and other concerned individuals. The ADA's vision is a life free of diabetes and all its burdens, and our mission is to prevent and cure diabetes and to improve the lives of all people affected by diabetes. So let's talk a little bit about diabetes advocacy. First, if you haven't already, I would encourage any of our listeners to sign up to be a diabetes advocate with the ADA. It's as easy as going to diabetes.org/advocate sign up. When you go there, you can share your name, your address, and email. And if you want to opt in to our new text messaging system, you can also share your cell phone number. By signing up as an advocate, you may be called upon to share your personal stories, so we know how best to direct your advocacy experience. Then there may be opportunities to target your advocacy by sending an email to your legislator through our action alert system, meeting with your state and or federal legislators. And this is important to introduce yourself, tell your story, and offer to be a resource to them on diabetes-related issues. You might also write a letter to the editor, participate in a legislative town hall, even submit written testimony or testify in person about a diabetes-related bill, or participate in media interviews. Now, I'll tell you that volunteers sometimes get a little intimidated by the thought of testifying before a legislative committee or even answering a reporter's questions. And I tell them this is normal. Sometimes I get nervous too. But what I tell folks is this is your story. No one can tell your story better than you. In fact, you are the expert on your diabetes, your personal diabetes experience. And I can tell you that personal experiences are the most compelling for policymakers to hear. They personalize the data and statistics that we all know can be a bit dry and boring, but your personal story is what they will remember. Now, I want to give you an example that illustrates the impact of personal stories. Pre-COVID, ADA hosted an annual Lobby Day event in Washington, D.C. And this was an opportunity for advocates from around the country to descend upon Capitol Hill and meet with their members of Congress, both on the House and the Senate sides. And one thing I'll always remember is a meeting we had with a former member of the Michigan congressional delegation. Among the advocates in our group were a couple high school students who had diabetes. Our meeting went as any other meeting, as we described diabetes and made our asks in support of federal appropriations to support diabetes research. The congressman, of course, listened and his staff took notes. But it wasn't until one of the teenagers checked her continuous glucose monitor, or her CGM, that we really got their attention. Immediately, the congressman asked what it was, and the advocate explained the CGM and demonstrated how it and the insulin pump that she had actually worked. At that point, we had their undivided attention, and they could see beyond the statistics to see exactly how someone manages their diabetes on a daily basis. I can't stress enough the power of personal stories. So I want to share just a little bit about some of ADA's legislative priorities at both the federal and state levels of government. Our goal is to make sure that people with diabetes pay less at the pharmacy counter for the insulin they rely on to live. Therefore, on the federal level, we are supporting the Insulin Act, which, because Congress has to have an acronym for everything, stands for Improving Needed Safeguards for Users of Life-Saving Insulin Now. That spells out insulin. So the Insulin Act would cap out-of-pocket costs for insulin at $35 for commercial insurance plans. We're also supporting the Amputation Reduction and Compassion Act, or the ARC Act. And this legislation was introduced because every 3.5 minutes in the United States, someone with diabetes has a limb amputated. But 85% of these are preventable. The ARC Act will provide awareness and education opportunities and improve access to amputation prevention services, thereby reducing the tens of thousands of preventable diabetes-related amputations that occur every year. We also support the Treat and Reduce Obesity Act, or TROA, which would, among other provisions, enable Medicare coverage of FDA-approved anti-obesity medications. I know we're running a little low on time here, but I also want to speak very briefly about two of ADA's state priorities in Michigan. Last year, ADA convened a coalition of stakeholders, including several healthcare professionals, in a successful effort to improve access to CGMs for Medicaid beneficiaries. As a result, effective June 1st of this year, coverage has been expanded to those with type 2 and gestational diabetes. And also burdensome criteria, eligibility criteria, such as requiring 3 or more insulin administrations per day, multiple daily blood glucose testing, and frequent adjustments to insulin have been eliminated. And prior authorization has been eliminated for those beneficiaries with type 1 and gestational diabetes. Now, like the Insulin Act at the federal level, we are supporting legislation in Lansing to cap co-pays for insulin. Currently, 25 states plus the District of Columbia have enacted some form of limitation on out-of-pocket cost sharing for insulin. House Bill 4015 would help people in state-regulated health plans by capping the cost they're paying for their insulin at $50 per 30-day supply. Our hope is that the cost-sharing limit would be reduced to $35 to be in line with Medicare and what many other states have already done. That's a little bit of who the ADA is, how we approach advocacy, and some of our legislative priorities. And I appreciate the opportunity and happy to answer any questions that Elise, you, or Dr. Kim might have.
I just want to say thanks, Gary. First of all, somebody's got to be out there fighting for everybody, and we appreciate everything that American Diabetes Association is doing, to bring all this to the forefront on a legislative, situation, being able to make some of those changes. I know that there's been a lot more activity more recently, it seems like, when it comes to the cost of medication and co-pays and things like that. And are there other things that are in your future, other things that you're shooting for to be like, what's next, based on some of the movement that's happened?
Yeah, well, we've seen some momentum on lowering the out-of-pocket cost for insulin, which we all know how expensive that is. Many people don't realize how expensive diabetes supplies are also. Mm-hmm. And so we've been successful in a few states in capping the cost sharing on diabetes supplies as well. So I don't know if that's the next big thing, but it certainly builds upon the success that we've seen in all of these other states, and I think will certainly help people living with diabetes to not only have assistance with the cost of their insulin, but also their CGM, their insulin pump, even their test strips and other supplies like that. So I think that's another area where we're going to be engaged pretty actively.
I think the point you made about people being able to share their stories is so important. And I know people get intimidated, or they don't think they know, how they're going to be viewed, or if they're going to look the right way or talk the right way, but I don't think people understand that they're the experts of their own experiences. And
I tell them nobody on the planet can tell your story like you can.
yeah,
So I think once they get started, and as Kristen was talking about her family member and Michael talking about his experience, it just comes natural. And they might be nervous at the beginning, but when they start talking about it, it's just second nature because that's what they live with every day.
can you tell us, Gary, are there any other organizations that the ADA works closely with?
Yeah, on the CGM issue that we worked on with Medicaid, we also worked. I mentioned we worked with a coalition of folks. That included the National Kidney Foundation. We've worked with AARP. They are particularly interested in the insulin copay caps. The Association of Diabetes Care and Education Specialists, Michael and Kaylee, as members of that organization, are tremendously helpful and a great partner in a lot of the policy work that we do. So I think there's quite a few organizations that we partner with depending on the issues.
That's great. Kelly, any last question that you have at all, or?
Well, I have a quick question. I'm not sure if Gary, if you're the right person, or Michael, with so certainly there's the question with the cost of once you have diabetes, but the importance of screening, is that something that's covered by insurance? Is it one of those essential preventative health care systems, or should we expect a copay as part of doing that regular screening?
Michael, you're probably best positioned to answer that.
Yeah, Dr. Kim, I'm not exactly sure on that. But imagine, depending on what your copay is for like a standard, examination, I believe it would go with that. I don't know that there's any extra coverage for, diabetes screening.
Yeah, I agree. And I think it does come under preventive health care. So I would think it would be no more than your standard copay, if that.
Great, thank you.
I do want to mention that I would say at least 2 years ago, we had added a page on our website here at the Center for Rural Health called Diabetes Know Your Risk. And that's at nmu.edu/ruralhealth/diabetes. And we have provided a Know Your Risk. It's a 1-minute online pre-diabetes risk test that goes right to the American Diabetes Association. So I would like to just welcome anybody who's interested in this. It's just a few questions. It takes less than a minute to take. It's just a good way to kind of have that snapshot, and provide more information to you just based on some quick questions. So I would like to thank all of our guests tonight, Kristen Cambenzi with Upton, Michael Parks with UP Health System Marquette, Kaylee Laquia with UP Health System Marquette, and Gary Daugherty from the American Diabetes Association. We cannot thank you enough for all the information that all of you have provided tonight. This has been a great episode, and I'm very hopeful that people in the Upper Peninsula will learn something from having, watched tonight's program. So thank you so much. And I wish all of you the best for some great holidays coming up in the next month.